So I finished the Parkinsonism, biochemical understanding, the pathways and the clinical features and various drug treatments, where they occur, what are the common side effects, and what classes of drugs you use, what are the other forms of treatment. Now we go for the dystonic disorders. That is the dyskinetic disorders. Just put it in the slide. These are very common disorders. You need to know a few things, particularly tremor, you need to know very in detail, because that is such a common thing. So let's see them. Basal ganglia, hyperkinesis, or whereas Parkinsonism is a hypokinetic disorder, this hyperkinesis, dopamine deficiency, these are dopamine excess disorders. So see what are the disorders and also which part of the brain is affected. This you must remember. Which part of the brain is responsible for these syndromes? Parkinsonism, substantia nigra, unilateral hemiplegismus, subthalamic nucleus, chronic chorea, caudate nucleus putamen, acetosis, putamen thalamus, dystonia, cerebral cortex. Okay? Cerebral cortex, myoclonus, central tegmental tract, and then the rhythmic palatal and facial myoclonus, inferior olivary nucleus, olivodendroid connections. This table summarizes where is the pathology. Parkinsonism, substantia nigra. Hemiplegismus, subthalamic nucleus. Chorea, caudate nucleus and putamen. Acetosis, putamen or thalamus. Dystonia, cerebellar cortex, thalamus. Myoclonus, central tegmental tract. And rhythmic palatal and facial movement, myoclonus, inferior olivary nucleus, or olivodendroid fibers. Okay, having said that, these are the things we are going to see. Tremor, chorea, dystonia, tics, myoclonus, and then valleys. And then we have got one more thing called the fibrillation, which is not an abnormal movement disorder. It's only due to anterior horn cells. This one, that fasciculations and fibrillations of muscle, they don't produce effective contraction of the joint, which we are not considering as the hyperkinetic disorders. Okay? Some books you may see fasciculations and fibrillations also, but they are not hyperkinetic disorders. You don't have to worry about it. So I want to know about tremor. What is tremor? Tremor is involuntary, rhythmic, oscillating movements. So they are involuntary movements, all right. They are rhythmic. There is a rhythm in that. In the tremor, oscillating movements in limbs or the whole body also due to alternating contraction of the agonist and antagonistic muscles. This definition you must know. What is tremor? Tremor is an involuntary movement. And it is a rhythmic movement, oscillating movement of the limbs of the whole body, alternating contraction of the and relaxation of the antagonist and agonistic muscles. Okay. So what are the various types of tremor? Resting tremor, rest tremor, pill rolling tremor, very common in Parkinsonism, resting tremor or pill rolling tremor. Action tremor can be postural, kinetic, intention. Action tremor, rest tremor. Action tremor, pill rolling, movement and tremor in Parkinsonism. Action tremor, postural, occurs during maintenance of a posture. Whenever you ask him to stand or then wall sit or do anything or stand in one particular position, the tremor is brought. Kinetic means during voluntary movements. Intentional means appears in movement and increases when it comes to the nearer to the aim. So he will not have tremor here. Once he reaches the bottle there, then the tremor. That is called the intentional tremor. Kinetic tremor, postural tremor, intentional. Physiological and pathological. Physiological, sometimes tremor can occur due to various other physiological causes, particularly anxiety, and then fever, and all those things. Essential tremor varies. A tremor is a series of involuntary, relatively rhythmic, purposeless oscillatory movements due to intermittent muscle contractions. Simple tremor involves only a single muscle group. Compound tremor involves several muscle groups. So sometimes they will ask, what is a simple tremor? What is a compound? If one muscle group is affected, simple. Complex muscle groups are affected, compound. Maybe unilateral, maybe bilateral. Usually distal, usually finger and hand. May also affect feet, legs, and tongue, eyelids, jaw, may occasionally involve the entire body. So how can I classify tremor? Mainly rest, often suppressed by memory. Resting tremor, he wants to do activity, resting tremor is suppressed. It's a classical feature of Parkinsonism. So postural tremor is ask the patient to outstretch and this is a posture or stand erect. This postural tremor is brought out by key. That's why you ask the patient to put like this. Then why are you doing that? I want to elicit postural tremor. Oh, wonderful. Postural tremor. Okay, tremor at rest, postural tremor. And in the examination, what are you doing like that? So I mean, what type of tremor? Postural associate. Okay, physiological tremor, anxiety, thyrotoxicosis, essential tremor, salbutamol, very common. So you go on prescribing salbutamol for children, that bottle will be there, salbutamol, 2 milligrams per 5 ml. So the mother, cough is not reducing for the child. She thinks, one more dose, 4 or 5 times she will increase, thinking salbutamol is a cough suppressant. She does not understand cough syrup, she thinks, and then excess of salbutamol. Child gets, let us say, in 12 hours, 8 milligrams. It's good enough for the child to. Several times children are a severe whole body tremor. I asked, what are you giving? I gave cough syrup. Which cough syrup? Aspirin, Ascoril. That's the reason. Stop it and tremor. Many times we had. So very important, salbutamol. Lithium, valproate. People are treated with sodium valproate. They come with tremor. The tremor is because of the valproate. I reduce the valproate, tremor disappears. You understand? Clinically, this is very important. This is usually in the postural, the tremor of the drugs, tremor of thyrotoxicosis, essential tremor, anxiety, drug tremor. These are physiological tremor. These are all postural tremors. There won't be any tremor at rest or while doing movement. Only ask them to keep a particular position, they have. Okay. Mainly on movement, but sometimes with sustained posture, cerebellar disease. This is a clinical question. Intention tremor, cerebellar disease, postural tremor, that is the list, and then the Parkinson's disease, tremor at rest. Okay. Now, so oscillations, coarse tremor, fine tremor, slow tremor or coarse tremor is 3 to 5, rapid or fine tremor is 10 to 20, amplitude may be fine, coarse or medium, relationship to rest we have already seen, rest attenuate when the part is it's okay. Now, postural, kinetic, task specific. Postural tremor is evident when the limbs are maintained in the anti-gravity position. That's why you're keeping the limbs. Gravity is pulling like that, to try to keep their anti-gravity position, it comes. Okay, then kinetic tremors, appear when making an voluntary movement. That's particularly intentional tremor. Terminal part of the movement will have the intention tremor, finger nose test, and knee heel test will bring it out. So, cerebellar disease, ask him to do this. Fast pointing also will be. Or he will come and here. So finger nose test. Likewise, heel knee test also. Okay? Progressively worsens during the movement. Approaching the target causes the lips to shake. Now, tremors are accentuated by emotional excitement. Many normal individuals develop tremor with anxiety and apprehension and fatigue, particularly during examinations. Before Viva, why? Anxiety. Anxiety tremor or Viva tremor. Physiological tremor is present in normal individuals, which is fine frequency, can occur in persons with anxiety, fatigue, fright, and rock climbers tremor, it is also called. Because of fatigue they develop, they are climbing mountain. And after reaching some height, they become tremor. Tremor is because of the fatigue. In conditions with increased adrenergic activity. Then familial prevalence of essential tremor, enhanced physiological tremor, first appearance anywhere between second to sixth decade, tends to progress very slowly. Postural and action tremor made worse by anxiety, also called senile tremor. Okay, that is over. Okay, physiological tremors, fatigue, anxiety, cold, hypoglycemia, hyperthyroidism, caffeine, steroids, salbutamol, mainly among the drugs, valproate, salbutamol are very important drugs for essential tremor, postural tremor. Again, it is rhythmic. Already we have discussed. Now, how do I treat tremor? So you have now understood mostly three types. What are they? Intention tremor, cerebellar disease. There will be positive pointing. As he approaches the object, tremor will become. And the moment he stops, the tremor is absent. Whereas tremor at rest only the tremor is there, one side or both sides. It can involve the whole body also. But once he initiates a movement, the tremor is gone. Whereas postural tremor, outstretched hands, you keep it. You have the physiological tremor, anxiety neurosis, thyrotoxicosis, salbutamol, valproate, essential tremor, senile tremor. These are all. So whatever it is, how do I treat? Beta blocker, propranolol, anti-epileptic drugs, primidone, clonazepam. The drugs of choice are primidone and clonazepam and not valproate, because valproate by itself can produce tremor. Don't give valproate to treat the tremor. Beta adrenergic blockers. Propranolol is the drug. Sustained release preparations are available. You can use once a day also instead of giving four times a day with an ordinary Inderol or propranolol. Now, what is dystonia? Sustained muscle contractions frequently causing twisting and repetitive movement or abnormal pose. Like so, sustained postural movements, they put different. These are dystonic, just opposite of Parkinsonism. This is a hyperkinetic disorder. If you give levodopa to them, it will further aggravate. And you should not use any Parkinsonism drugs there. Abnormal postures will be there. And you can see the dystonia there. The baby, you can see segmental, two adjacent regions, focal, only one region of the body, multifocal, more than one part of the body, hemidystonia, the body, generalized. Focal, segmental, multifocal, hemidystonia, and generalized. And then focal dystonia may be blepharospasm. As though he is squeezing the eyelids. Only the eyelids. Or oromandibular dystonia. You can see those movements on the pictures there. Cervical dystonia, graphospasm, also called the writer's cramp. Graphospasm is also written. He writer's spasm like thing. Spastic dysphonia, and then toy or foot dysphonia. So these are different types of dysphonias. How do dystonias? How do I treat? Clonazepam, baclofen, tizanidine. Clonazepam, baclofen, tizanidine, it can be used. Botulotoxin, Botox also can be used for the dystonias. And anticholinergic drugs also can be used. Now, chorea. What is chorea? Chorea is involuntary, unpredictable, quasi-purposive, non-repetitive, irregular movements, arrhythmic, unpredictable, jerky movements which involve the extremities and the face in continuous and random sequence. These are called the chorea. So, you can see hereditary chorea, Huntington's chorea, hepatolenticular degeneration, that is the Wilson's disease, where ceruloplasmin deficiency causes Wilson's disease. I have one patient, so we had last time one conference, a spiritual conference, and that gentleman, the Swamiji of that afternoon, is a Wilson's disease patient. A patient with Wilson's disease, where ceruloplasmin deficiency is there, and he used to have tremor there. I asked him, and he gave me the medical. Then I understand it is because of the Wilson's disease, he is having the chorea. Okay, Huntington's chorea and Wilson's disease are hereditary disorder. Secondary is Sydenham's chorea or Saint Vitus dance. It's called the rheumatic chorea. Rheumatic fever can develop chorea, and that is called the Sydenham's chorea or Saint Vitus dance. Infections, encephalitis, systemic lupus erythematosus can produce secondary chorea. Drug-induced chorea, antipsychotic drugs, estrogens, levodopa itself can produce chorea because levodopa increases dopamine, excess dopamine is a dyskinetic moment, chorea can participate. Metabolic and endocrine, hyperthyroidism, hyperglycemic, non-ketotic coma. Hyperglycemic non-ketotic coma, this can also produce choric movements. Senile chorea, people who are aged, they will have dystonic movement, part hyperkinetic movement, that is senile chorea. So what are the types of chorea? Hereditary chorea, secondary chorea, drug-induced, metabolic or endocrine, senile. Under the hereditary, Huntington's, Wilson's. It will be short notes for you. Discuss chorea, short notes. This slide and the subsequent. Chorea is a dystonic moment. It is a hyperkinetic disorder of the basal ganglia where there will be dopamine excess or the facilitatory pathways are more. Dopamine 1 receptor activity is that fate is coming. Hereditary, Huntington's disease, Wilson's disease, secondary, Sydenham's chorea, rheumatic chorea, infections, encephalitis, systemic lupus erythematosus, drug-induced, antipsychotic drugs, estrogens and levodopa. Metabolic and endocrine, hyperthyroidism, hyperglycemia with non-ketotic coma, and then senile chorea. This is the final. You see the picture there, senile chorea. And now, this is the Saint Vitus dance. Very, very early in 18th century itself, they have discussed this one because of rheumatic fever and levodopa in Parkinson's patients. So you can, whenever you use levodopa, it can produce chorea. Oral contraceptive pills, psychiatric drugs. Vascular diseases of the basal ganglia like thyroma, systemic lupus erythematosus, degenerations like Huntington's, post-infectious, Sydenham's chorea, other causes, thyroid also. Now, so distribution is variable, may involve one extremity or one half of the body, that's called hemichorea, occur most characteristically in the distal parts of the upper extremities, like the end of this one. Unlike tremor, this is a tremor is a repetitive movement. Okay, tremor means there will be flexion action like this, antagonist and agonist. Whereas quasi-purposive, non-repetitive, arrhythmic movement of the distal parts of the limb. Maybe extremities, trunk, face, tongue, lips, and pharynx. Repeated twitching and grimacing movements of the face, change constantly in character and location, involve most important part of chorea is very atypical. It doesn't fit into any picture, and one movement is not similar to the other movement. Okay, so involvement of the vocal cord may cause vocalizations. There will be choric cry. They may have a intense cry also. Difficulty in maintaining the phonation. Sometimes aphonia also can occur. So they interfere with distort the voluntary movements, and later may be short, jerky, unsustained. When asked to hold the hands outstretched, there may be constant random movements of individual movements. So in tremor, what will happen? You ask him to keep, the hands will shake. If you ask him to this finger, the piano movements. So as though he is playing a piano. It's called the piano playing. Movements will be there. The patient holds the examiner's finger in her fist. There is a constant twitch of the individual fingers. This is called milkmaid grip. Okay, so give the two fingers. Ask this one. As though he is milking your fingers. He cannot constantly hold the fingers like other person. This is called the milkmaid grip. Blink rate is increased. They will be having frequent blinking, and then there is hypotonia in the skeletal muscles, decreased resistance to spasm. Then Huntington's disease, autosomal dominant, irregular rapid jerky movements, progressive dementia, gait is unsteady, and with a tendency to bob and weave, and then facial grimacing, involuntary movements of that. Psychotic drugs, treatment for chorea. What is the treatment here? Haloperidol is the treatment. For tremor, what is the treatment? Beta blocker. Okay, beta blocker is the main treatment for this one. For dystonia, the main treatment is, what is the treatment for dystonia? Dystonia we have seen. Dystonia is clonazepam, muscle relaxants, anticholinergic. Okay, dystonia. Botulotoxin also can be used. Whereas for case of chorea, the treatment is mostly, what is the treatment? Haloperidol is the treatment. Sulpiride or Sonapax are the psychiatric drugs. Okay. Now, athetosis, more important one. Athetosis means, what is athetosis? Without fixed position. Thetosis means to have a fixed position. Athetosis, he doesn't have a fixed position. He will be changing the posture. Involuntary, irregular, very coarse, athetosis, involuntary, irregular, very coarse movements, and somewhat rhythmic. Writhing movements are squirming in character, twisting movements are there, hyperkinesis are slower, more sustained, larger amplitude, involve the extremities, face and neck and trunk. In the extremities, they affect mainly the distal part, fingers and toes. Movements are characterized by a combination of flexion extension, abduction pronation, and supination, often alternating to varying degrees. This is athetosis. See? Also called torsion dystonia. Athetosis, the other name for athetosis is torsion dystonia. See? Flow randomly from one body part to another, the direction of the movement changes randomly. Affected limbs are constant motion without fixed position. Athetosis means no fixed position. Hyperextension of the fingers and wrist and pronation of the forearm may alternate with full flexion of the finger. First of all, the fingers are extended and then forearm is pronated. Then the fingers are flexed, forearm. Various positions and disappear in the most important thing is this disappear in sleep. Voluntary movements are impaired, coordinated action, and they may be difficult or impossible. They cannot do any coordinated activity. What are the causes? Congenital, atherosclerotic, and then pathological changes are in the caudate and the putamen. As I showed you in the first slide, you see the hands. There in that picture, so many hand forms are there. No one particular position. Sometimes chorea and athetosis may combine together. It's called chorioathetosis. Movements that lie between chorea and athetosis in rate and rhythmicity and may represent a transitional phase. Now, myoclonus. Myoclonus is involuntary, brief, sudden, 0 to 1 second spell. Stops. After that, suddenly you'll have a jerking. Myoclonus. It may be distributed. Muscle contractions producing visible movements. Myoclonus. Okay. So, essential myoclonus, symptomatic myoclonus in Huntington's disease, Alzheimer's, liver disease, paraneoplastic syndromes, physiological like sleep myoclonus, and hiccups. Hiccups is one form of diaphragmatic myoclonus. What is diaphragmatic? Hiccups may be diaphragmatic myoclonus. I had one patient who was the son of a cardiologist in Chennai. He was cardiologist in SRMC hospital, Narasimhamurthy. His son is, he had several times he used abdominal pain and hiccups. So what happened? He went pillar to post, all ultrasound, this one, CT, MRIs, and imagings with all sorts of contrast dyes, ERCP, everything is so the abdominal pain could not be looked at. Then that fellow is known to me, this doctor. He, sir, you see my patient, my son, one said, it's typical diaphragmatic myoclonus. Treat the myoclonus, the whole thing is gone. Nothing to do with the intra-abdominal pathology. They have missed it. I remember that boy, hardly studying intermediate or something, doctor's son, and we have identified it as diaphragmatic myoclonus. So what I am saying is, Myoclonus with the diaphragm can present as intractable hiccups and abdominal pain. So the hiccups will be coming, the myoclonus, unless you suppress the myoclonus. I have put him on myoclonus treatment, and definitely it has subsided immediately. Okay. Treatment of myoclonus. Okay, valproate you can use. In fact, I have used valproate and carbamazepine. Together I have used carbamazepine and valproate. In the paracetam is also a neurotropic drug. Some people give non-specific drug, paracetam, neuracetam. It's available as neuracetam. And they think it is a neurotropic drug. I don't much use that, but then carbamazepine, valproate combination, or clonazepam with carbamazepine can be used for myoclonus. A combination of clonazepam plus carbamazepine or valproate plus carbamazepine will be ideal for myoclonus. So you have seen, and this slide. The single or repetitive, abrupt, brief, rapid, lightning like I showed you now, you'll be sitting there. Suddenly some jerky movement will come. It's a single, not like a tremor, not like a thetosis, not like chorea. Chorea is all forms of smooth. Etherotic movements are very coarse. Etherotic movements are dystonic. Choric movements are smooth, like a dance. Saint Vitus dance. Tremors are rhythmic contractions. Those two are arrhythmic contractions. Myoclonus are single movements. Suddenly like that, yes. Some people will say they will be having, suddenly they will be doing like this, as though he's going to hit somebody. So these are the myoclonic movements. Abrupt, brief, rapid, lightning-like, arithmetic, asynergic, involuntary contractions involving portions of the muscles, entire muscles or groups of muscles. Movements are quicker than chorea. Chorea is slower and smooth, seen principally in the muscles of the extremities and trunk, but involvement is often multifocal, diffuse, and widespread. May involve facial muscles, jaw, tongue, pharynx, and larynx, may be successive or simultaneous, and many muscles may be involved. Myoclonus may appear symmetric myoclonus on both sides, or such synchrony may be an attribute unique to the myoclonus. It may be symmetric or asymmetric also. Now, what is the classification of myoclonus? Classified in numerous, including positive myoclonus versus negative, epileptic, non-epileptic, stimulus sensitive versus spontaneous, rhythmic versus arrhythmic, anatomically peripheral versus central, spinal, segmental, brainstem, cortical, etiology, physiologic, essential, epileptic, symptom. So many ways you can classify. What is hysterexis? Hysterexis may be viewed as a negative myoclonus, the transient, unwanted, abnormal relaxation. So hysterexis is flapping tremor. So as typically used, the term myoclonus refers to positive myoclonus. Okay, physiological myoclonus occurs. Normally, sometimes when we are even normal, suddenly we feel jerky movement. That's okay once in a while. Okay, hypnic jerks and then hiccups, diaphragmatic myoclonus, essential myoclonus, no other abnormalities, sporadic, sometimes, in the family. So myoclonic epilepsy, juvenile myoclonic epilepsy, JEM, Jan syndrome, these are myoclonic epilepsy can occur. The myoclonic epilepsy is one form of, focal epilepsy. So these are the various conditions where the myoclonus is a feature of a prominent seizure disorder. Metabolic disorders, subacute sclerosing panencephalitis, SSPE, and then Halo-Verdens patch syndrome, Creutzfeldt-Jakob disease, Alzheimer's, Wilson's, Huntington's, corticobasal degeneration, viral encephalitis, general paresis, GPI, general paralysis of insane. You don't have it now. We used to see cases of GPI due to syphilis. You don't luckily see GPI here. Hashimoto's encephalopathy and lipoidosis. These are the various secondary myoclonus underlying disorder. And finally, tics. Tics are habit spasms. Tics also are called the habit spasms. Some people will have a tic, they'll be doing something like that. There's some high moment. They'll be having those sort of, these are not dangerous actually. Tics are repeat, unlike, the myoclonus, which is a single movement. Tics are repeated. Tics are repetitive, rapid, usually brief, involuntary, non-rhythmic, stereotyped movements which involve the face, axial muscles, proximal limbs. Tics interrupt normal voluntary motor activity. Okay? Simple motor tics, complex motor tics, so simple vocal tics, complex vocal tics. So echolalia, coprolalia, these are called generalized syndromes. Tourette syndrome, these are various types of tics. So simple tics are, I showed you, blinching, twitching, shrugging, handshaking, scratching, kicking. Okay? And then moaning, grunting, hissing, clicking, shouting. These are related to the vocal. So these are various kinds of tics. How do I treat? Clonazepam, paclofen, neuroleptics. Okay, haloperidol can be used. So then, Ballism, that is sudden onset of involuntary, violent flinging movements of the lips. So what happens is sudden onset of flinging movements as though he is throwing himself to one side. This is half side, it's called hemiballism. Usually affects only one side of the body. Hemiballism. Appearance is similar to baseball pitcher's wind-up caused by a lesion in the subthalamic nucleus, usually after a cerebrovascular accident. This is called ballism, and Greek word ballismos means jumping moment. Latin ballista refers to ancient military machine, which is similar to a catapult and used for throwing large stones. The catapults, what is the catapult? They used to have a large stones. They use that, and then they bounce it like that, the catapult. So that is something like that. These moments are also like that. Hemiballism. Hemiballism, sir. So wild, flinging, forceful, incessant, uninterrupted, continuous movements in infarction or hemorrhage, contralateral, subthalamic nucleus, disinhibition. So distribution and characteristics. These are the very rapid, forceful, involuntary, proximal portions, fully developed. You may be unilateral, may be bilateral. They may spare the face and trunk and often disabling. So last slide, I have given you the comparison between chorea, athetosis, and ballismus. You can slowly read that slide. With this, the lectures on basal ganglia diseases, the hyperkinetic and hypokinetic syndromes are over, including their physiology, biochemistry, the pathways, and also clinical features. All these things I'm going to share these presentations with you. With this, we will end this particular presentation. So there are various types of dystonic disorders. So I've covered almost everything, the dystonic disorders. Now I'm going to end the class. So the other class is coming up. Already people are lined up. So I may have to put them. Yeah. Okay. Now we will stop here this lecture and go ahead with the next one. Okay. So now what is the next class? I'm going to take something on the brainstem. The 3 levels of brainstem: medulla, pons, midbrain, and thalamus. 4 levels. All the 4 levels, maybe two I will try to combine, and first give you the neuroanatomy, then look at the disorders here. Like various syndromes, crossed hemiplegias are there. So all those crossed hemiplegias, vertebrobasilar insufficiency, those things we will see. So finally, we will see the spinal cords we have finished, basal ganglia we have finished, brainstem will finish, finally go to motor and sensory cortex, and then follow it up with epilepsy. With that, some part of neurology will be over. Okay. Fine then. So